Good morning, everyone. I'm Bob Chaloner. I'm the Chief Administrative Officer at Stony, Brook, Southampton Hospital, and I'd like to welcome you to our Ask the Expert session about tick-borne diseases. A little bit of history. The hospital started this regional tick center probably 6-7 years ago. Six years ago. We had a number of things that we were interested in doing with the tick center. Number one, it started when our staff in our emergency room really started asking us we need to do something because they were being inundated with people showing up in the emergency room with all manner of questions about ticks and tick-borne diseases. And so the idea was born to develop a resource center where we can get information out. And we're trying to get information out to the community, really two groups. One is to use the public better information because we were discovering a lot of misinformation, ways to remove ticks that frankly are just wrong, that are going to put you more at risk. Treatments that weren't necessarily very, very helpful. It may even be dangerous. And so we felt there was a need to get good, scientifically proven information out to the public. And the other group we wanted to educate was our clinicians, our doctors and our nurses, many of whom were seeing tick-borne diseases for the first time and not necessarily having good information either. So we've continued over the last 6 years to do a number of educational events. Last year, in fact, in the community, we did over 40 public seminars for the community. And we have several sessions where we bring in researchers and the latest and greatest information about tick-borne diseases to meet with our clinicians so that our doctors and nurses can be educated and brought up to speed. The other thing we wanted to do was create a helpline, and we have a telephone helpline, and it's 631-726-TICK, T-I-C-K, 8425, and that's staffed by a nurse, Rebecca Young, who's here somewhere today. Right over here is Rebecca. And she's been dealing, last year she got over 800 callers around the world, interesting. I think we had a caller from Australia and New Zealand in that part of the world. How they found us, I don't know. But we do, Rebecca's goal is to get out information people can call, and also to direct people to the appropriate resources. We also publish a lot of material. We put more and more material up on the web and written material and get resources out into various groups. And we've become a partner with the county in their efforts to try and educate people across Suffolk County as well. We've also developed a program for the local schools called TickWise. And April Boitano, who is a school teacher, has developed a curriculum, and she's worked with, I think the number's over 3,000 children at this point out in the public schools, and doing innovative things like putting a little tiny tick tattoo on the kid, and then the kid goes home and challenges their parents to find the tick, so the parents get used to looking for ticks on their children and removal of them. And that's a program we've extended into the local summer camps and libraries as well. The other thing we're doing is we've done a lot of grant support to hand out tick removal kits with information about ticks in it, tweezers, the appropriate magnifying glass. You'll all get one of these at the end of today. We ask you to take it home. If any of you have a community group or something you would like us to speak at or get information out, please let us know that, and we will be happy to work with you. Today I'm going to introduce a number of people that we've invited in as experts. We have some clinicians, we have an expert from the county on ticks and how to identify ticks, and we always wrap up with Jerry Simons on some very important prevention tips and common sense sort of prevention tips. We live in an area that's known for its outdoor life. We love being outdoors. I live in the Northwest Woods in East Hampton. We're full of ticks, but I don't want to spend my summers indoors. And the information that we get is hopefully going to help us all be safe and happy and able to enjoy our environment. And we hope you will walk away today with some new information to help you deal with the issue that we have of tick-borne diseases in our communities. We will take questions at the end. We're going to ask you, and I think there have been pads distributed. If you have any questions, please write them down. We'll take questions at the end, and I'll moderate those questions once we finish with our speakers. So I'm going to introduce our first speaker, who's Dr. Scott Campbell. Scott Campbell is a medical entomologist who received a BS from Muhlenberg College and a PhD from Cleveland State University. Currently, Dr. Campbell is the laboratory chief at the Arthropod-Borne Disease Laboratory for the Suffolk County Department of Health Sciences Services and has been involved in public health and research of arthropod-borne diseases for approximately 25 years. He and his staff are responsible for countywide surveillance for all mosquito-borne and tick-borne pathogens that cause human disease. Dr. Campbell is a member of the Scientific Advisory Panel to the Regional Tick-Borne Disease Resource Center. He is also a member of various professional organizations, enjoys presenting at professional meetings, and has contributed to the scientific peer-reviewed literature, and he's been a very, very willing and eager resource to help us out here on the end. So please welcome Dr. Scott Campbell.
Thank you. Good morning, everyone. All right, so we'll talk about ticks, the diseases that they can transmit, but other speakers will talk about the actual diseases, and then we'll talk about tick removal and related things to ticks. All right, so here in Suffolk County, there's primarily 3 species of ticks that we're concerned with regards to medical importance. The first one is the black-legged tick, also known as the deer tick, the American dog tick, and the Lone Star tick. And I'll talk about each of those. So we have an egg. The egg hatches, and out comes a 6-legged larva. So it hasn't fed yet. And the ticks acquire the pathogens that cause the disease from the blood meal. So larvae that come out of the eggs typically do not have any pathogens that cause the disease. They have to feed on blood meal that has it in it, and then in subsequent stages they can transmit it. So the larva takes the blood meal, molts to the 8-legged nymph, so that's how you can tell the difference between the two stages. And now, if it fed on a blood meal that has a pathogen, it can be infected and transmitted to something that's uninfected, like a human, or another animal, and infect the animal as well. They take a blood meal, and they molt into either a male or female. They mate sexually. The female lays a clutch of eggs and dies. So it's one stage for each cycle, larva, nymph, and adult, and then they die. So as they acquire the blood meal, the infection rate in the nymph is about half of what the adult female is. Females typically transmit, males don't. They just kind of hang out and mate, and that's it. So they don't really transmit anything. But so typically in Suffolk County, let's say, nymph can be 25% infected with the pathogen that causes Lyme disease. The adult is 50% infected. So it goes from about 25 to 50% infection rate over their life cycle. So ticks quest. They don't drop from trees, they don't fly, they don't catapult. All they do is typically either wait on vegetation for a prospective host to walk by, or they'll actually move. Some species will actually move towards a host if they sense any kind of CO2, any kind of warmth or CO2 from that host. So as I said, they take a blood meal. Here's a nymph emerging from a larval case. This is an engorged nymph. You see how big they get. And then this is a female laying a clutch of eggs. They lay anywhere from 2,000 to 6,000 eggs, a female. Depending on the species and the quality of the blood. We can get a lot of larvae from one female. Here we go. Okay. So this is the life cycle. In Suffolk County, ticks take about 2 years to go through that life cycle, egg to adult. All right. So if you look here, the eggs are laid in the spring. They emerge in the summer. They feed. The larvae overwinter and molt and emerge as nymphs in the spring. And then in the fall, they emerge as adults. As you can see, this is a CDC diagram. You can see that the risk actually is primarily the nymph, whereas if you remember what I said, that's 25% infected, whereas the adult is 50%. And the reason the risk is greater for the nymphs, even though they have a lower infection rate, is because they're smaller and they're less likely to be found. Okay, so it's very important when Jared talks about tick checks. Very, very important to look for small nymphs. Okay, here in this, the importance is, I'll start with the larvae. Larvae, I said, come out in the summer, right? And then they overwinter, the nymphs. So this is the greatest risk of Lyme disease for the black-legged. And then in the fall, you have the adults. The take-home message here is that anytime during the year, you can actually be subjected to tick bites. It's not just a summertime event. Adult black-legged ticks are actually active in any day that's above 40 degrees. You can actually come in contact with ticks. Okay? Press it once and press it twice. All right. All right. So I said I would talk about the pathogens, and so the black-legged tick transmits primarily 4 pathogens: Lyme disease, human granulocytic anaplasmosis, babesiosis, which is a protozoan. These are 2 are bacteria, and then the blossom virus. We've never had an identified case in Suffolk County of blossom virus disease, but we know the virus is here. But the infection rate is very low, and that's probably one of the reasons. The other good news is one tick can have multiple pathogens, so you can get multiple diseases from one bite. I was facetious when I said good news. It's obviously something you really, really need to be aware of, that you can get multiple diseases from one bite. So the animals, I said, the pathogens are in the blood. So the black-legged tick, the mouse is with the reservoir host of all the pathogens that the black-legged tick transmits. So Lyme disease, babesiosis, anaplasmosis, and blossom virus. It's all found naturally occurring in the blood of white-footed mouse. Mouse is fine, doesn't bother them, but any tick that feeds on the mouse will pick up the pathogens if the mouse is infected. If it feeds on a mouse in a subsequent meal, it'll affect the mouse. So that's the relationship between the mouse and the tick. The relationship with the deer is that the adult stage feeds on the deer, but they don't acquire anything other than the blood from the deer. So they don't acquire any pathogens, but obviously very important for continuing the life cycle. The American dog tick, I only have the male and female up here, although there is the egg, larva, and nymph stages, but they don't bite. The larva and nymph do not bite humans. They're very restricted on rodents. They won't bite humans. So you just have to look for the adults, male and female. So they come out in the spring. They come out in April or so, and then they'll go into the summer. But they're not found until winter months. And they transmit Rocky Mountain spotted fever, bacterial infection. And in their life cycle, it's the meadow that is the important rodent vector, rodent host that is the reservoir for the bacteria that causes Rocky Mountain spotted fever. And then the adults feed on larger mammals, foxes, dogs, things like that. So the Lone Star tick, all stages look like humans, that's why they're here. You have the 6-legged larva, molts to the 8-legged nymph, and then you have the male and female from the fed nymph. Everybody recognizes that, right? And you can see size doesn't matter when it comes to species. They all have the smaller stages. So, one of the misconceptions is like, oh, it must have been a deer tick. It was small. It doesn't have to be. You have a small larval, small Lone Star tick as well, so they can bite you as well. And they transmit ehrlichiosis, and which is a bacterial infection, but they also are implicated in alpha-gal meat allergy, which is not a pathogen. It's just an allergic reaction to alpha-gal, which is found in the saliva of the tick. For Lone Star ticks, they don't really have a rodent involved. All the stages feed on deer. And deer is the reservoir for the bacteria that causes ehrlichiosis. So in the spring, you get nymphs and adults that come out, right? So they feed, and then in the summer, you get the larval Lone Star ticks, and that's when people say they've been bitten by chiggers. Chiggers are not found in Suffolk County. What individuals are being bitten by are larval Lone Star ticks. Chiggers are actually mites. You can see they look very similar. 6 legs, larval mite, chigger. This is the larval Lone Star tick. Looks very similar, feeds the same way, but when people say chiggers, please correct them and say, no, I heard that they are larval Lone Star ticks and not chiggers. We fight the fight together. But they feed the same way, as I said. So they don't go under the skin. Ticks or chiggers or ticks don't burrow under the skin. So they feed above the skin, and after they feed, they can leave a mark, and that is actually larval Lone Star ticks. Marks left by larval Lone Star ticks. And because again, you have the egg mass, you have thousands of eggs laid. Out of that mass come thousands of larvae, and so they're very highly concentrated. So if you walk through that mass of larvae, you can be bitten by those that many larvae. And but at that point, the ticks are gone. They fed and they dropped off in your bed or in your living room or wherever they may have dropped off. But they won't live in the house. Once they drop off, they'll dry out. But that's what they look like. All right, we're going to see a video, talk about some of the, or you'll see some of the things I've spoken about, questing, feeding, and things like that.
The hills are alive. With silent, waiting ticks. Their bites can transmit bacteria that cause Lyme disease and other things that can make us very sick. Protected by these palps is a menacing mouth, covered in hooks. First, she has to find a host. She can sense animals like us by the carbon dioxide we give off. She reaches out with her front legs. Scientists call this questing. It will use that claw to latch onto something, like your sleeve. Now you see her. Now you don't. Once aboard, she searches out a nice spot to bite into for blood. She lives 3 years, but in that time, she only eats 3 meals. A tick needs enough blood to grow from larva to nymph. Nymph to adult. And then for females to lay their eggs. Gross. Let's check out a nymph, a young tick. It's tiny. smaller than a freckle. To grow into an adult, it needs one blood meal, a big one. The front of its body is all mouth. It digs into us using 2 sets of hooks. The hooks wriggle into the skin. They pull our flesh out of the way and push in this mouth part, the hypostome. Those hooks anchor the tick to us for the long haul, like mini harpoons. While the speedy mosquito digs in, sucks our blood, and splits, all within seconds. A tick nymph stays on for days. 3 days if we don't find it before then. Compounds in their saliva help blood pool under the surface of our skin. The nymph sips it through its mouth parts, like drinking from a straw. When a tick is full, and I mean completely full, it falls off wherever it may be. Maybe onto your bed. That's if you don't nab it first. You might have heard that you should twist or burn the tick. Not true. Grab the tick close to your skin and just pull straight out. That's how you win the fight against those tenacious hooks. Hey, I'm health reporter Laura Clivens, standing in for Lauren till the summer. This biologist from the California Department of Public Health is collecting ticks in Berkeley. At this park, only 1% of the ticks carry Lyme bacteria, but in some places, 40% can be infected. So make sure to do a thorough tick check after you go hiking. And when you're done, check that you've subscribed to Deep Look. Happy trails!
Good one, right? So you saw them questing the legs on vegetation. So again, that's where they are. And so you have to keep that in mind when it comes to trying to protect yourself against those against tick bites, right? Being subjected. So where do you find them? The black-legged tick, it has to do with their host and how susceptible they are to desiccation. So some can live in dry environments than others. So black-legged ticks are very susceptible to desiccation, drying out. So they like woodland because it's covered, deciduous forest, dry or wet, moist understory with regards to the leaf litter and things like that. So you're going to find those in woodlands, and that's where mice and deer are. American dog tick, that's where the meadow vole is, right? So you're going to find them in fields where it's drier. They're less susceptible to desiccation from drying out. And lone-star ticks, they're not susceptible to desiccation as well, and they're found everywhere, typically where deer are found, which is everywhere, right? They come into yards, so you can find them around homes, or in your plantings or things like that. So you really have to be looking for ticks and after you've been outdoors, whether it's your home or someplace else in the town. And I was asked to talk about the Asian longhorn tick. This is a new tick that was discovered in 2017 in New Jersey originally. And since then, it's been found in 11 states. It doesn't appear to be a big issue with regards to human disease at this point. They've looked and they've not found any pathogens associated with it, although where it comes from in Southeast Asia, it does transmit some pathogens, so we're looking at it, continue to look at it closely. It actually can reproduce with parthenogenesis, which basically it doesn't have to mate. So where we find it, we actually just find females, no males. So it can produce eggs without actually mating with males. As I said, no pathogens have been found, but they do find them on pets and livestock. It seems to prefer livestock and deer, and that's where we find them feeding on mostly. But they have found it on people. I mean, there are some records of being bitten here, in the U.S., but it doesn't appear to be a big biter. Even places where there's huge numbers, they don't seem to want to bite humans. But the research is ongoing. You can follow, if you want to follow what's happening, is on CDC's website. They post updates. And this is data current to June 24th of this year. So it's rapidly in flux. We're looking at it every day, and they're adding stuff that may be of interest. Okay, so we already saw the mouth part. So this is the business end. This is the hyperstome of the tick, and when it embeds, it only goes to here. It doesn't go below. I've already mentioned it doesn't dig under the skin. These palps actually stop it from going any deeper, and you'll see from this. So here's a graphic of it, right? So this stops it from going in. And the best way to remove it is just getting a fine pointed pair of tweezers, which are actually in this tick kit that you'll get. They're excellent. Grabbing it close to the skin and pulling straight up. No Vaseline, no matches, no cigarettes, no gasoline, definitely no matches and gasoline together. That never ends well. And just pull straight up, okay? You don't want to squeeze the tick. You don't want to create like a hypodermic needle. You don't want to squeeze the contents. Those pathogens are actually found in the gut. And so you don't want to squeeze the tick and force the gut contents into the site, all right? Okay, so as I said, they don't burrow in, but you can see, here you can see the palps, right? The hyperstome is already in the flesh. But this one looks like it's buried in, but really you can see it's inflamed around, it's swelling around. So it looks like it's buried, but it's not buried, as you can see. So you just reach down and pull straight up, just like this. You want to remove the tick as soon as possible. We have about 24 to 48 hours, depending on the pathogen, to remove the tick. As I said, it's in the gut, and it takes time for that to move from the gut to the salivary glands, where it's put into the bite site through the saliva. So you have about 24 to 48 hours. That's why it's very important to remove them as quickly as possible. Don't squeeze the tick, and if you have that tick, keep it. Put it in rubbing alcohol, mark it with a date. It takes about 7 to 30 days for symptoms to occur. Or you can put it under a piece of tape, but I know people love to flush, they love to grind, they love to burn. I mean, vengeance is a good thing possibly, but not when it comes to a medical record. And that tick could be important for you to understand what you may have been infected with if you need to go to a medical provider. Okay? Here's another one.
Ticks are common in New York State, and they can carry disease, so it's important to check for ticks and to know how to promptly remove a tick if you find one attached. First, you'll need a pair of fine-tipped tweezers like these. They work much better than blunt-tipped tweezers or your fingers alone. You can do this yourself or ask a friend to help. Before you start, clean your tweezers with a little rubbing alcohol on a cotton ball. Now grasp the tick where the mouth is attached, which isn't always easy to see, especially on ticks the size of poppy seeds. But if you gently lift the tick with your tweezers, you can see that it's attached like a hinge. That's how you can tell where the mouth is. Get as close to your skin as possible with your tweezers. Now pull in a slow, steady, upward motion away from the skin. Don't twist, jerk, or wiggle it out. Your skin will pull up as the tick detaches, just like when you pluck a hair. Afterward, clean the bite site with rubbing alcohol and a little antibacterial cream. If the mouth parts stay in your skin, you can either leave them alone or try to remove them with tweezers, as you would a splinter. Keep an eye on the bite site for 30 days, watching for any kind of rash, including the telltale bullseye rash for Lyme disease, or for flu-like symptoms such as headaches, muscle aches, or fever. If any symptoms do develop, you'll want to see your doctor and make sure to let him or her know the date and location of the bite. Remember, not all ticks carry disease, and your risk for disease is greatly reduced if ticks are removed promptly. Knowing how to safely remove a tick can help keep you safe from tick-borne disease. Learn more at health.ny.gov/tick-free.
All right. So, further information. The Resource Center here in Southampton is a wonderful resource as Bob has already mentioned. Rebecca's great to talk to if you have medical issues. They have a lot of information, as you see in the back table. And the tick kits are awesome. We also have a lot of information on our website. I'll show you a picture of it in a second, but you can call that number, the hotline 631-787-2200, or email us at tick.prevention@suffolkcountyny.gov, or go to our website and reach us there as well. And CDC and your state health department have a lot of information as well. It's out there if you want to find it, and that's what our website looks like. There's a lot of educational material. It starts there, but it's a mile and a half long, so you'll find just about everything you could possibly think about with regards to tick on our website, or links to other websites to get them. And good piece of art. Thank you.
Thank you, Dr. Campbell. Anybody else's skin crawling? Mine is. Our next speaker is Dr. Anne Marie Wellens. And one of the things I neglected also to talk about is another mission, one of the things we're doing out with our Tick Center is supporting research around tick-borne diseases, both research on vaccination, hopefully better testing, the diseases generally, because we are such a reservoir for tick-borne diseases. And Dr. Wellens has been instrumental with a number of our experts in developing and working on some of the research that's happening. Dr. Anne Marie Wellens earned her BSN degree from the College of Mount St. Vincent, followed by her graduate degree in nursing education from Teachers College at Columbia University, and her Doctor of Nurse Practice at Stony Brook University. She also completed an MS degree in adult health at Stony Brook University. Dr. Wellens has worked with primary care since 2012 as part of Southampton Hospital's Meeting House Lane medical practice. In 2015, Dr. Wellens joined the faculty at Stony Brook University in the Advanced Graduate Nursing Education Program, where she continues to teach. She's currently a member of the Medical Advisory Panel of the Tick-Borne Disease Resource Center. Dr. Wellens is the panel's co-investigator in the Rutgers University National Institute of Health funded study on Lyme disease, which has as its goal to develop an accurate blood test to diagnose early Lyme disease. Please welcome Dr. Anne Marie Wellens.
I don't know, are you itchy? You feel itchy? I do. Okay. So I'm going to talk about the common tick-borne diseases. And like Dr. Campbell outlined, the tick-borne illnesses transmitted by the three species of ticks, the black-legged tick, the lone star tick, and the dog ticks. So the black-legged tick, Lyme disease is the most predominant transmitted tick-borne disease. So for every 10 cases of Lyme disease, there's one of the other diseases that are transmitted. It's kind of a good way to look at it in terms of prevalence. So the black-legged ticks, which is also the Zoodes scapularis, transmits Lyme disease, which is the most common, babesiosis, and anaplasmosis. Dr. Mineroff is going to talk about babesiosis, and I'll talk about generally the other tick-borne diseases. And then we have the lone star tick that transmits auriculosis, something called stari, which is southern tick-associated rash illness. There's no a pathogen for this particular, is not, this particular presentation has not been identified. And then Rocky Mountain spotted fever, which is a rickettsial disease, similar to the dog tick transmission, but it's a lesser, it's not as, the disease is not as severe as the dog tick transmission of Rocky Mountain spotted fever. And the also the alpha-gal meat allergy, which is increasing from lone star ticks. And the dog tick is Rocky Mountain spotted fever, and then tularemia. So So Lyme is the most common tick vector disease caused by the black-legged tick. So the infected ticks transmit the pathogen. The pathogen is a spirochete called Borrelia burgdorferi, and it's related to the syphilis spirochete. It's got a lot of similarities. It's a great imitator, so sometimes the presentation with Lyme disease can be very not straightforward. Usually, if anybody presents or experiences flu-like symptoms in the summer, like fatigue, fever, muscle aches, neck pain, flu is typically in February, it's not in July. So flu-like symptoms in the summer is not the flu, it's probably a tick-borne disease. So that's something that's really important to keep in mind. It should not be dismissed, these symptoms. Unfortunately, not everybody presents the same way. It takes 3 to 30 days after a tick bite to either have symptoms. There may be a rash. We like when we see rashes, but not every case of Lyme disease has a rash, or there may have been a rash that was missed or wasn't appreciated. But the symptoms can be vague and very evasive at times. Like sometimes patients will have some fatigue, but then it's compared to their baseline, or they have joint pain. So it's anything, if you're normally feeling tired and you are more fatigued, or you normally have some joint pain, but you have more joint pain. So you have to compare it to what a baseline is, but it doesn't always present the same classic textbook picture. And again, like I said, the rash may not be present in all cases. And children, we're going to have a separate presentation about children, but children are at very high risk for tick-borne diseases. Children and retired folks. Children because they're low to the ground and their play areas are habitats for ticks. And also children frequently present with fevers, very, very common. And if they're not treated early and they go on to have Lyme disease, they can develop a lot of issues with like OCD symptoms or food aversions, irritability. So it's very important to really, with children, because they're so high risk, very important to check children every day when they're outside to prevent this. So ticks for Lyme disease, like the other pathogens that ticks transmit, is ticks feeding for more than 24 hours increase the likelihood of disease. And for Lyme disease, the classic bullseye rash is maybe 50% of the time we're seeing a rash. But flu-like symptoms, like I mentioned, joint muscle aches, fever, headache, neck pain, fatigue, mental cloudiness, having trouble concentrating, sometimes a facial palsy, like a droop of the face, or visual changes can occur. So with Lyme disease, one of the problems is that if someone presents with a plaque or rash, or a rash associated with a tick bite, if they don't have symptoms, just the rash, they need to be treated. So this is another misconception. There are individuals or family or friends will say, oh, you only go to the doctor if you have symptoms. Not correct. You need to be treated with antibiotics if you have a rash associated with a tick bite. Or you have a rash and you didn't see the tick. And then you can be treated. Unfortunately, with Lyme disease, there's no early blood test. The issue with the organism is the organism does not stay in the blood very long, so it can't be cultured easily. The spirochete likes to go to collagen-rich tissues, and what is that? Joints, the nervous system, and the heart. So it's very hard to culture. We can wait if someone is not treated, about 3 weeks. Antibody response will occur, and then there's a test called a 2-tier ELISA Western blot that can be done at that point, but we don't really want to wait 3 weeks to see if you mount an antibody response and now you're sick. You want to get treated right away. But this test can be done if there's a suspicion that the patient had Lyme disease. And you check that, and sometimes it does come back positive, and of course they'll be treated. The proteins, this test looks at the proteins which are signature for the pathogen. And there's, some false positives and there's some cross reactivity, so it's, you have to be really careful with this test. The treatment, fortunately, is doxycycline, and that would be, so if someone presents with a rash with flu-like symptoms, or just flu-like symptoms, any of the above, doxycycline is prescribed. And it's for up to 2 to 4 weeks. More antibiotics, longer protracted antibiotics is not recommended. The long courses of doxycycline are not given to children under 8. And doxycycline is a tough medication. It's hard on the stomach. It should be taken with food, non-dairy food, even though the label says take on an empty stomach. And of course, the individual has to complete the course. In my study, I recruit patients that present with a rash and they're enrolled. And when I do my callbacks, they have a rash, no symptoms. They're placed on 2 weeks of doxycycline. So when I do my telephone calls, it is not uncommon for the patient to say, are you still on your antibiotics? Well, I'm feeling I don't have any symptoms, so I stopped taking the antibiotic. So it's a very, very good drug. The takeaway is to ensure that you take the full course of antibiotics. If you take the full course of antibiotics early, even if you don't have symptoms, you just have the rash, you will 99.9% of the time eradicate the infection. If the antibiotic is stopped, or if you're having symptoms, then you need to call your provider because there may be an alternate medication like amoxicillin. Doxycycline for outdoor workers is probably not the best idea because exposure to the sun can cause sunburns. So those individuals, amoxicillin is a good alternative. Also, there's Septin is another alternative medication. But doxy is the go-to. And again, I can't stress completing the full course of antibiotics. Very, very important, because if you don't eradicate the disease early in the course, then you'll run into issues with lingering symptoms down the road, and you don't want to have that happen. I always tell patients to take probiotic with the antibiotic. And then, of course, lots of fluids and supportive care is very important. This is the classic symptoms of Lyme disease. So this is the classic erythema migrans rash or the bullseye rash. This is not always the case with Lyme disease, that you'll have this classic rash. And where does the rash usually occur? Well, where the tick bite are common in dark, warm places. So in the underarms, in the back, particularly the lower back, in the groin area, and behind the knees. Those are favorite spots for ticks to burrow and feed. And then you see this facial palsy. If this occurs, sometimes patients come in and they'll have this, and it's most likely because we're in a Lyme endemic area that this is Lyme disease, and they need to be treated. Very, very important, even if this is the only symptom that the patient has. And then the swollen knee. The old term is the Montauk knee. This is not this is not osteoarthritis. It's osteoarthritis is normal wear and tear, but this is swelling of a large joint. So this is the classic, can be classic presentation. And not all rashes are the same. Now this is a classic textbook picture of the erythema migrans. You see the center redness and then clearing, like this is the bullseye here, clearing, and then the outer ring. And again, this can be not appreciated. It could be missed if you don't look, if you're not looking at all those areas of your body on a daily basis, if you've been outside for that 3 to 30 day window after exposure. So it could be missed. And also in darker skinned African American individuals, it may not be appreciated. It may look more like a bruise, which is not always easy to see. So this actually is a picture that was sent to me from one of my students. It was his 7-year-old daughter who had this rash after being in a park a few days earlier. And it was misdiagnosed by the doctor as an infected mosquito bite. So when he sent it to me, it was like, no, it's definitely a Lyme rash or a tick rash. So she needed to go on antibiotics, which she did, which is good. So not all rashes. And you can see here, often, you see this center, and with the Lone Star tick, they're very irritating bites, and you can a lot of times see an ulceration in the middle, and sometimes that's confused for a spider bite. So you have to be really, really careful not to dismiss this type of presentation. Like I said here, these are rashes that are very light and faint, and they don't necessarily have all the classic characteristics of the typical EM or erythema migrans bullseye rash. So that's Lyme disease. So if you catch it early, you have definitely do a tick check every day if you're outside. Even in walking in the grass, you want if you're not on asphalt, you need to do tick checks, and you need to get, and really, really be careful and observe or note if you have any tick bites or any rash. If you go on doxycycline or one of the other antibiotics and you take a full course, the chances are everything is going to be fine. You're going to eradicate the disease. The other, you have the Lone Star tick transmits tuberculosis, and the deer tick transmits anaplasmosis. These are pathogens that stay in the blood. They affect the blood, so they're easy to culture. And the symptoms, even though they come from 2 different ticks, the symptoms overlap. So again, these flu-like symptoms. However, usually these presentations, patients are sicker than they are with just regular Lyme disease. They have higher fevers, night sweats, very, very ill. And if they can also have a co-infection, so it's not uncommon to have one of these other tick-borne diseases that, along with Lyme disease. So you can have a rash, could be associated with Lyme disease, but if they're really, really sick, if they present really ill, like almost, these are the patients that usually wind up in the emergency room because they're so sick. We can do blood testing, and we can do antibody testing as well to determine if there's tuberculosis or anaplasmosis. And sometimes just regular chemistry panel, a regular blood, complete blood count, we'll see platelet counts are low, the white blood cell count is low, and also liver enzymes elevated. This doesn't happen in Lyme disease, but it does happen in some of the other, like auriculosis, anaplasmosis, and also babesiosis. Again, doxycycline course is going to eradicate this as well. So doxy is basically all other tick-borne diseases except babesiosis. So that's something that Dr. Monroe is going to talk about. Rocky Mountain spotted fever, I'm just going to talk about. It can be transmitted by the Lone Star tick, but the classic symptoms is a rash on the hands, the palms, and the soles of the feet with very, very high fever, a headache, and then, very bad muscle pain. And again, the treatment is doxycycline. The other tick-borne diseases I do want to mention, there's Borrelia miyamotoi. It's similar to Lyme disease. It's a different strain of Borrelia, but it does respond to doxycycline, and we do have testing for this as well. The story that I talked about before is the southern tick-associated rash illness. And again, no test is available for this, but it does respond to doxycycline. And then the Powassan encephalitis, which is a viral, it's a flavivirus. This is transmitted within hours of feeding, of a tick feeding, and the symptoms can be very severe, particularly in the very young and the very old, because their immune systems may not be as hardy in that age group. And usually these are patients that wind up in the intensive care unit because they're so ill, and there's no treatment. It's a viral infection, so these patients have to be treated supportively, usually on life support, and medications to maintain blood pressure and everything. Very high death rate, 10 to 15% death rate, and 50% of the survivors have residual or ongoing neurological deficits. So it's scary. Fortunately, we don't have any cases on Long Island, but there have been cases in New Jersey and upstate New York, so that's a scary one. Now, I want to talk about the alpha-gal meat allergy. This is interesting in the sense because most food allergies are protein. This is a carbohydrate or sugar, and it's transmitted. We get inoculated with these Lone Star tick bites. So the Lone Star larval bites that people term at the end of the summer, we term as sugar bites. Those can transmit the alpha-gal. So any stage, the larval, the nymphs, and the adults can transmit this alpha-gal. And this alpha-gal is a carbohydrate sugar that we get, if we get inoculated with this, we don't have the gene to process this carbohydrate. The gene is old world monkeys, apes, and humans don't have this gene. So what happens is that you get inoculated with this sugar, this carbohydrate, and then our immune systems build up antibodies to it because it's recognized as foreign. And then with that, if we ingest meat, we can then develop an allergic reaction. So, and then what happens is when we build up these antibodies, if we consume any mammalian meat that has a hoof, so that would be cows, pigs, sheep, anything like that, then what happens is we develop an allergic reaction. And it's a delayed allergic reaction, which is unusual too, because most food allergies are immediate. So this is like a 4 to 6 hour window after ingesting meat that someone will wake up. Usually they have their cheeseburger at 6 o'clock in the evening, and then by 11 o'clock they're waking up with either abdominal pain, rash, itching, or they can have a full what they call an anaphylactic reaction, where you have swelling of the tongue and the lips and a compromised airway. So that's a medical emergency. So because we don't have this gene to synthesize this alpha-gal, we build up this allergic response, so that when we eat meat, mammalian meat, we can have these really terrible symptoms. And that's a medical emergency. Now again, just emphasize that all stages of the Lone Star tick can transmit this. It's a delayed allergic reaction, and it can resolve over time if there's no further exposure to these bites. But again, you have to be under the care of an allergist, and it seems to have a worse reaction with the higher fat meats. And the problem is that once you are sensitized to this, you have to have an EpiPen, and we can't do testing for alpha-gal. And that can be monitored because as an individual is not exposed to these continual bites, the IgE will start to come down. And very important for these individuals, most of my patients that have alpha-gal, they are under the care of an allergist, but they just decide to not eat meat. You can eat fish and chicken, you just can't eat mammalian meat, so they just don't eat meat. They just say, I'm just not going to chance it. But they have to introduce meat very slowly, and that's why they have to be under the care of an allergist, because you don't want to just, if you have an alpha-gal meat allergy, you just don't want to pick up a cheeseburger and start eating it, because you can go into a severe allergic reaction. And then it's very important for these patients that they have to read labels, because gelatin is from beef. So you can be sensitized, you can get a reaction from gelatin, and gelatin is in pretty much everything. You also have to be careful when you go out to eat, because someone could order clam chowder, and then this is fish, but there's bacon in it. So anyway, so it can get a little tricky, and some people are really compromised, their quality of life is compromised with an alpha-gal meat allergy. And that's it. Thank you.
Thank you, Dr. Wellens. And now I'd like to introduce Dr. Max Mineroff. Max Mineroff attended medical school at Stony Brook University School of Medicine and completed his residency in emergency medicine at Stony Brook University Hospital, where he was also chief resident. Dr. Mineroff is board certified in emergency medicine and has worked at Stony Brook Southampton Hospital's emergency department for the past 11 years. Dr. Mineroff is a member of the medical advisory panels of the Regional Tick-Borne Disease Resource Center. In addition to seeing patients in the emergency room, he serves as medical director for local EMS agencies in East Quogue, Hampton Bays, and East Hampton. He's also the medical director for the Southampton Town Ambulance. He is Stony Brook Southampton Hospital's representative to the former chairman of the Suffolk County Regional Emergency Medical Advisory Committee. Please welcome Dr. Mineroff.
Thank you, everybody, for coming. So, as an ER physician, babesia is one of the tick-borne diseases that I find most interesting. It's the type of illness that will typically drive you to come to the ER and be this sick. And it's something that if we make a diagnosis that day, get you on appropriate treatment, we've done you a great service. So what is babesia? So babesia is an intra-erythrocytic parasite transmitted by the tick. And what does that mean, basically? So Lyme disease is this little spiral-shaped organism that kind of goes and hides in our body. And most of these infections want to hide somewhere. So what babesia is, it's this little parasite or protozoa, single-celled organism that goes and invades our red blood cells and hides inside of them and eventually causes them to burst. It's important to us here because it's very endemic in our area. It's called non-optimal area or island fever for a reason. The islands, Nantucket, Martha's Vineyard, Lock Island, and us here on East Long Island are very, very, very endemic. Up to 7% of residents from Shelter Island who were tested had antibodies in their body from the disease. The other thing that's important to know about it is that it's often a co-infection of Lyme disease, because this is carried also by the black-legged tick. So, the life cycle of babesia. So it has the reservoir and a host of the white good mouth, similar to anaplasma, similar to Lyme. When those young ticks get their blood meal from the mouse, the bacteria can then, the protozoa can then replicate within the mouse. They then go and come and they bite us, and they can transmit the infection to us. We tend to be a dead-end host, basically meaning we're not running around getting hit by lots of ticks. In theory, someone with babesia could give a tick babesia, but the likelihood of that happening is very, very low. The other thing that's interesting about babesia is because it's in our red blood cells, that prior to 2015, when we started really screening for babesia in our blood supply, people would get transfusion-related infections with babesia, which can be quite catastrophic because instead of being bit by a tick, getting a little bit of this pathogen in you, having it replicate and grow, it becomes, here's 20% babesia in your body all at once. And so the reaction can be much more violent. So human infection with babesia, how does that happen? We've talked and we've watched these great videos of the tick splashing, but you get bitten by the tick, you don't know, it introduces the pathogen into our body, and then over the next several weeks, this parasite invades and replicates inside of our red blood cells, causing them to burst, which is a very inflammatory process in the body. It invades into the liver tissue and the spleen to hide our immune system and also to continue to reproduce in those areas. And then, with or without medical intervention, our spleen and our immune system clear the infection. And then Unfortunately, sometimes it doesn't. You know, they say if you're sick enough to be hospitalized for babesia, there's somewhere between, you know, a 5 and 20% chance you won't make it. You know, so it's very important that people who are more susceptible to illness be treated quickly and right away. You know, and again, the nice thing about babesia is is that we can make a diagnosis that day. You know, we can see it in you. Whereas with Lyme disease, you know, unless you have a classic rash, it could be a whole bunch of different things that you have. You know, we don't really know. And we send off these tests that are pretty good, you know, but we find out a week later that maybe we should do something. And for me as an ER doctor, I'm a very much immediate gratification person. That's not very satisfying. You know, going and say, you may have this, you may have that, we're not sure, we'll find out in a minute. And then chances are I never really find out either because you're off to somewhere else. Symptoms of babesia, you know, if you're going to get sick from it, then you know, not everybody gets sick from it. You're not going to really wonder if you had it. You know, Lyme disease people often wonder. You know, they feel a little achy, their joints are a little more, than we were saying. You know, babesia is you've been hit by a truck. You know, you have a high fever, you know, 104, 105, you know, shaking, chills, severe fatigue, headaches, body aches. Your spleen may grow big on you, and your liver may grow big on you. And because you're bursting all these red blood cells, you end up with either blood in your urine or the byproducts of the blood cell making your urine look very dark, like black water fever for that reason. So, most commonly, you know, as these illnesses present in the summer months, just due to the life cycle of the tick and also how we spend our time outside for some of those. So what is the clinical picture? So, as we said, in healthy people, it's often asymptomatic illness. You never know you had it. Your body takes care of it. Your spleen goes out of your system, and you know that's about 25% of adults and half of the kids, because kids are tougher than us, right? That get through this without ever really complaining about it. However, you know, if you are at higher risk, basically, you know, the extremes of age, you're immunosuppressed for any reason, you have liver disease, be it alcoholic liver disease, hepatitis of some kind, things that make you have a poor immune system, you have a much higher chance of things. Not having a functional spleen is very good. Patients with sickle cell, if you get babesia, are in a lot of trouble. If someone's had trauma and had their spleen removed, there's a lot of trouble. So you're sick enough to come to the hospital, and we're going to work you up to see if you have because you got this fever in the summertime, and no obvious other source. So most of us, they call it a flu-like illness, but with the real flu, you should really have a sore throat and a cough. You know, that's the flu. It's a respiratory illness primarily that then makes you feel ill and have diffuse symptoms and myalgias in the body. Whereas this, there's no particular symptom besides not feeling well. So what are we going to do when you show up? You know, we're going to draw some blood. We're going to look on that blood. We're going to run some tests, and we get back within an hour and change. We're going to find things out. We're going to do a basic CBC, which is your basic blood counts. Oftentimes you'll have a low white blood cell count, not necessarily as low as with the anaplasma and ehrlichia, which are actually invading the white blood cells and causing them to burst. The hallmark of the disease is being anemic and having a low hemoglobin. And because it invades the red blood cells and bursts the red blood cells, our red blood cell counts are low. And then we also see these low platelet counts. So anytime you see somebody, any patient I see in the summertime that has a low white count, a low platelet count, I'm going to put you that patient, and if they have a normal red count, they're going to go on doxycycline while we're waiting to get results back. If they have a low hemoglobin as well, now we're thinking they probably have disease. So we send what's called a parasite smear to the lab. And that's where, this is a manual test, so it's a lab tech, someone has to physically do this. This isn't like a machine just giving you an answer like most of our other lab tests. But they look at both we call a thick and a thin smear, so they smear some blood on the slide, one time really thin, one time kind of thick, and they look at it, and they look to see if they can see the parasite inside of the bloodstream. And that's, these guys, inside of the red blood cell. And then they give us a approximate percentage of how many of the red blood cells are affected. And you can then sort of start to base our therapy a little bit on that. We do send confirmatory tests, your tick-borne disease panels out on anyone. Anyone who has one tick disease, you kind of just check for them all, because chances of co-infection are high. And we'll send off our antibody testing and then the PCR testing, which is what we're looking for the actual DNA of the parasite in our system, and the antibody testing is for our immune system response. The immune response can last for a long time. That's why the 7% of people on Chaloner Island having antibodies. That doesn't mean 7% of them all have Babesia at once. They've had it. Okay, so how do we treat it? Supportive care is a big part of this, like every one of these illnesses is giving you fluids, treating your fever, letting your body do what it does better than we do in medicine and heal you, right? Then we also want to put you on some specific antibiotics. And where Babesia differs from all the other infections is that Babesia is not killed by doxycycline. You can pretty much, with all tick-borne disease out there, put somebody on doxycycline, whether you know what they have or not, and be right. And they'll get better. Babesia, you won't. Primary regimen is something called a Tick-Borne and azithromycin, which everyone's heard of azithromycin, that's a classic Z-Pack. Use that cocktail together, and that's the preferred treatment method. The secondary regimen is giving quinine and clindamycin. Okay? This is very similar to the treatment for malaria, which is in the world the most common intra-erythrocytic parasitic infection out there. Right? We also, I most of the time will put people on doxycycline as well at this point, just for the high rate of co-infection with Lyme or another tick-borne disease. You just don't want to miss it. You're sick at this point, and it's I'd much rather throw the kitchen sink at you than try to be very careful about what we do. The most aggressive therapy that we have for treating Babesia is something called exchange transfusion. And this doesn't happen very often, but if you come to us at Stony, Brook, Southampton, and we see that you're someone who's immunocompromised, and you have a higher than a 10% load of the bacteria when you look at that smear, we're probably going to transfer you up to Stony Brook proper, because exchange transfusion is not something done within a community hospital. And chances are they're not going to actually do an exchange transfusion. They're probably going to still treat you the same way. But if you're not getting better over several days of being on antibiotics and you're showing this high percent of infection, for them to actually go and take a large portion of your blood out of you and give you new blood clears the infection and gives you a much better shot at making it. And that's it.
Thank you, Dr. Minera. Next, I'd like to welcome Dr. Patricia Coyle, who will be talking about Lyme disease in the nervous system. Dr. Coyle is Vice Chair and Professor of Neurology at Stony Brook University Medical Center, as well as the Director of Stony Brook Multiple Sclerosis Comprehensive Care Center. Dr. Coyle received her MD degree from Johns Hopkins School of Medicine, where she completed a fellowship in neuroimmunology and neurovirology. She established a successful research laboratory in addition to building a busy clinical practice at the Stony Brook University Medical Center. Dr. Coyle is a member of the Scientific Advisory Panel to the Regional Tick-Borne Disease Research Center. Her areas of expertise include multiple sclerosis, neuroimmunology, and neurological infectious disease, in particular Lyme disease. She's currently involved in a number of therapeutic trials testing new immunotherapies for MS, as well as studies addressing the neurological aspects of Lyme disease. Dr. Coyle is in demand both nationally and internationally as a lecturer on MS and neurological infections, and we're very grateful for the time she spent with us.
So I'm delighted to be here to talk about Lyme disease in the nervous system. So the first thing to emphasize is Lyme disease is a systemic infection. It may not involve the nervous system at all. It's also a bacterial infection. Lyme disease is eminently curable with the proper antibiotics. Again, Lyme disease should be cured with the proper antibiotics. That's the value of treating a bacterial infection. You can get reinfected, by the way, but you should be cured by appropriate antibiotics. Now, this is a systemic infection that targets 4 body organs, as we heard: the skin, we described that, the joint, particularly in North America, in the US, the heart, rarely, but that can be fatal, and the nervous system, both the central nervous system and the peripheral nervous system. And for the CDC, about 15% of reported cases will involve the nervous system. Neurologic Lyme disease is less common than Lyme arthritis. Why would some people get infected with this bacterial spirochete, Burgdorferi, and somebody gets neurologic disease and somebody doesn't? There are many different strains of Burgdorferi. There are some strains that are more likely to invade the nervous system, and some strains that are more likely to cause nervous system disease. So it's likely that what strains you're inoculated with when the tick bites you, and what the size of the inoculum is, are important factors. Probably an element of your immune system, how effectively and rapidly you can mount a response, and maybe even some of the genetics, the genes that somebody has, probably all play a role in who develops nervous system Lyme disease. Now, one of the peculiarities about Burgdorferi and this bacterial spirochete is that it's inoculated into the skin, and there's an explosion of growth, and if somebody was to biopsy that, you could pick up spirochetes, and then it disseminates, we believe by the blood in particular, to seed its target body organs, including the nervous system, but then you never see a lot of spirochetes again. You never have a large number of spirochetes. And Burgdorferi is not particularly destructive to tissue. So what does that mean? It really means that it's the host immune inflammatory response that's probably producing a lot of the symptoms associated with Lyme disease. The spirochete itself is not very tissue destructive. There is some inflammation, low grade, but it really is our immune inflammatory factors that are probably responsible for a lot of the symptoms. That would explain why, when we get treated for neurologic Lyme disease, all the symptoms don't go away immediately. They gradually fade as the immune inflammatory system comes back to its baseline. Now, one important take-home is there are some very important, highly suggestive neurologic syndromes for Lyme disease. So when you live and you practice in a Lyme endemic area, it means that it's mandatory to screen for Lyme disease in somebody who presents with these neurologic syndromes, particularly during summertime. And hopefully everybody is smart enough to realize that. Diagnosis. As a neurologist, if I'm concerned about neurologic Lyme disease, my expectation is most likely spinal fluid has been looked at. My expectation is, unless there was a contraindication, there would likely have been a lumbar puncture done and cerebral spinal fluid examined. That's sort of standard if you are suspecting a nervous system infection. Okay, so in my opinion, that is very, very important. It's something that we would commonly request or do. In general, if I am dealing with neurologic Lyme disease, I want to use intravenous antibiotics, a third-generation cephalosporin. They are the most penetrating. Now, there's literature that suggests that oral can treat mild neurologic syndromes. This may be true in pediatrics that seem to handle Lyme better. We'll hear about pediatric disease. But if you look at the literature, the limited data is virtually all from Europe, where they say that for neurologic Lyme disease, or as it's been called, neuroborreliosis, I don't like that term because it's not as specific as neurologic Lyme disease, oral and IV seen as good. That's a different genospecies there. Lyme disease from Europe is very different, has fundamental differences from North America. And we have clearly seen neurologic disease after courses of oral doxycycline, for example. So I personally, at this time, prefer the more penetrating intravenous antibiotics that patients seem to respond to it. Now, there's no doubt in our area this is sort of highly suggestive time lock to the summertime, May through October. Can you present with Lyme disease at different times? Yes, but it's way, way, way less common. So May through October is the top period where if somebody comes in with a neurologic syndrome, you should be thinking, could this be neurologic Lyme disease? Because if it is, it's a bacterial, eminently treatable infection that you want to give antibiotics to. If it's not an infection, then you don't want to give unnecessary antibiotics. Now, there is no doubt that Lyme disease can have multi-symptoms that are pretty nonspecific, like headache, joint pain, muscle pain, fatigue, foggy brain, palpitations. None of those are specific to Lyme disease, but having a multi-symptom complex like that, along with a neurologic syndrome, increases my suspicion that they could have a neurologic Lyme disease syndrome. So I'm asking about that, and I'm looking for that. We know that 50% of neurologic Lyme patients will not give a history of tick bite. So it's a 50-50 split. So that doesn't help me, but they all should have endemic area exposure. And quite frankly, we are in an endemic area. So during summertime, if there's a neurologic presentation, somebody should be asking, could this possibly be neurologic Lyme disease? Now, what do we see? Facial nerve palsy. Facial nerve palsy, seventh cranial nerve. So the person presents with drooping of one side of their face. Often people are scared they've had a stroke when they wake up and look at that. The eyelid can't close on one side. Now, in a central facial weakness, such as a stroke would do, the forehead is spared. In the cranial nerve palsy, the seventh cranial nerve, the forehead is involved. So there will be difficulty in wrinkling of the forehead in the weakness of one side of the face, or both sides of the face. And Lyme disease is one of the relatively more restricted causes of bilateral facial nerve palsy. So if you have a bilateral facial nerve palsy, it slightly increases the likelihood that it's Lyme disease. Do you know what data showed from many years ago on Long Island? Somebody who presents with a, quote, Bell's palsy, peripheral facial nerve palsy in summertime, 25% have neurologic Lyme disease. 25%. So this is a mandated evaluation for possible neurologic Lyme disease if somebody presents with a facial nerve palsy during the summertime on Long Island. Now, other signs that it's involving the peripheral nerve rather than a central issue. Is there any tearing issue, either increased tearing or decreased? Is there a hearing issue, typically hyperacusis, being bothered by noises on that side? Or is there loss of taste on the anterior 2/3 of the tongue on the side of the facial weakness? Those are all markers that it's the cranial nerve 7, the peripheral nerve that is involved. So that's a highly suggestive syndrome for neurologic Lyme disease in summertime. Somebody presenting with a facial nerve palsy. Now, acute painful radiculoneuritis, most common neurologic syndrome in Europe. We don't see it that often here. It's also referred to as bandwidth. This presents with severe spinal pain, often between the shoulder blades. And then you can get spinal nerve root features, what are called dermatomal, myotomal, weakness along part of the arms or hands, numbness that might develop, winging of the scapula. It's interesting, these people have no headache or stiff neck, yet they have a florid meningitis when you look at their spinal fluid. Lots of white blood cells, they have meningitis. Anybody who presents in summertime with severe unexplained spine pain needs to be investigated for neurological Lyme disease. Aseptic meningitis, the so-called viral meningitis or aseptic meningitis. Meningitis is inflammation of the lining membranes of the brain and the spinal cord. So it presents with new headache and stiff neck. Now, the typical causes of a bacterial meningitis are life-threatening, and the people are real sick. But a lot of viruses cause meningitis, and that's basically benign. It's going to do fine. So it's going to be milder headache, milder stiff neck. The person won't look toxic. They really won't look sick. However, Lyme disease, a bacteria, can cause a meningitis that mimics the viral aseptic meningitis. So it's mandatory. Anybody in whom there's a suspicion of a viral aseptic meningitis in summertime needs to be screened for Lyme meningitis, because you need to treat them with antibiotics, which you don't use in the typical viral meningitis. And then the late Lyme encephalopathy. And there's current controversy about this. The late Lyme encephalopathy are people that complain of subtle cognitive memory issues. They're not demented. They're functioning okay, but they know they're not as sharp, and other people are picking it up. Mentally, cognitively, they're not as sharp, okay? Now, there's controversy about whether this is a CNS brain infection or is not. And there are current new guidelines being written for the diagnosis and treatment of Lyme disease by the Infectious Disease Society of America, the IDSA, and the American Academy of Neurology, the AAN, and the American College of Rheumatology, ACR. They've been put forth to be reviewed. They're kind of conservative. They're kind of discouraging testing, and they're kind of going with these shorter courses of antibiotics. They think late Lyme encephalopathy is not a central nervous system. I kind of disagree. I kind of disagree with that, and I would certainly treat late Lyme encephalopathy with intravenous antibiotics. If you do cognitive function testing in late Lyme encephalopathy, there are objective abnormalities. Some of them will have small lesions on a brain MRI, and when you spinal tap them, it is not uncommon to have low-grade, not dramatic, not florid abnormalities, but low-grade changes in cell count, protein, and you would be looking for intrathecal Lyme antibody production. So I would treat them as though they had a CNS infection, and they do improve with antibiotics. So how do you work up somebody who's you suspect may have neurologic Lyme disease? Well, having positive antibodies indicates that person's immune system has seen the Lyme agent, Burgdorferi, and mounted an immune response. And the majority of neurologic Lyme patients will be Lyme seropositive. If they're not, and I'm suspicious, then I'm looking for their getting early abortive antibiotics that can interfere with making appropriate antibodies. So maybe they were artificially converted to a seronegative state. That's uncommon, but I'm looking to see if they could have gotten early abortive antibiotics that we know can interfere with making antibodies to the Lyme agent. MRI scans, typically normal in neurologic Lyme disease. Only about 25% will show lesions on imaging of the brain, so there's not a high yield. The expectation is most neurologic Lyme patients will have fairly normal imaging, although you may see enhancement of the facial nerve, and occasionally you'll see lesions. Spinal fluid, to me, is key. I'm looking for an increase in white blood cell count, an increase in protein, and I'm looking for what's called intrathecal Lyme antibody production, where you check for Lyme antibodies in the blood and in the spinal fluid at the same time, and show there's a relatively higher proportion in the spinal fluid than in the blood. Not explained by leakage, because there'll be leakage in it, okay? That there's a higher proportion of reactivity. That is the best current indirect test documenting CNS infection with the Lyme agent. Unfortunately, right now, we are missing a key biomarker that tells us you're infected or not. And people are searching for this from a research point of view. And this is the sort of workup that I would do. How do I treat? This is a bacterial infection. It's eminently curable. The sooner you treat effectively, the better the outcome. So I'm going to choose IV antibiotics for neurologic cases. This is IV ceftriaxone, not at the higher dose that they use for very bad bacterial meningitis, but at 2 grams once daily that can be run in over 30 minutes. You do not need to be admitted to the hospital for this. We would typically put in a line that could be used, typically a PICC line, particularly since we treat for 28 days. We treat for 4 weeks, typically. Okay. We tell people that they need to go on acidophilus or probiotics because the antibiotics can wipe out their normal bowel flora and there's a slight risk of C. difficile colitis. If they develop GI issues, they need to be checked for that. Also, we have a new understanding of the gut microbiome. So the gut microbiome is very important in the body's immune and inflammatory system. So you want to promote gut health. So taking probiotics or acidophilus would be very important. If we have a lining, we make sure they're aware it shouldn't be painful or red. That would be an issue that needs to be checked. And there have been rare cases of gallbladder disease reported because ceftriaxone is excreted in biliary sludge. Why do we choose to do 4 weeks when the guidelines are going to say do 2 to 4 weeks for bad neurologic cases and 2 to 3 weeks for milder neurologic Lyme disease cases? Because anecdotally at Stony Brook many years ago, we had some neurologic Lyme patients who lapsed after 3 weeks of antibiotics, and they did not after 4 weeks. So this is a personal experiential history that made us go to the 4 weeks. So the 4 weeks is the higher end, but I can tell you it seems to be very well tolerated, and we have seemed to have good results. We virtually never treat longer than that, never treat longer than that. We don't have people coming back. So, what are the important things about neurologic Lyme disease in an endemic area such as this? The recognition of the key syndromes, the facial nerve weakness, the acute spine pain for painful radiculoneuritis, the mild meningitis, the late Lyme encephalopathy. Get to a neurologist who knows the nervous system and neurologic syndromes and how to evaluate and treat. Make sure you get an appropriate workup. Make sure Lyme was checked for. I personally prefer IV antibiotics. We would need studies to help give us some data, evidence-based data about what is the best way, but we've done very well with this thus far. And if you have undiagnosed neurologic issues and live in an endemic area, in my opinion, it's probably reasonable to get a Lyme serology check. Now understand the guidelines that are going to be coming out, that are being discussed right now, discourage testing unless you have a very characteristic syndrome. But to my way of thinking, if you're in a very endemic area like we are, and you have unexplained headache, why wouldn't you want to get a Lyme check? Maybe it's not Lyme disease, but you're going to do other testing and evaluation that you wouldn't otherwise. We see the weirdos. We see the odd cases. I've told you about the major neurologic syndromes, but there are also a whole host of unusual things. Rarely Lyme disease can cause stroke. Rarely Lyme disease can cause dementia. It can cause a chronic meningitis. So I think in a very endemic area like we are, we should be looking in weird, unexplained, otherwise unexplained neurologic cases to make sure there's no role for a Lyme infection. Thank you.
Thank you, Dr. Coyle. Next, I'd like to introduce Dr. Christy Benary. Dr. Benary received her BS from State University of New York at Binghamton in 1997 and her Doctor of Osteopathy degree from Nova Southeastern University of Osteopathic Medicine in Davie, Florida in 2001. She completed a residency in pediatrics at Cohen Children's Medical Center in New Hyde Park in 2004, followed by chief residency here in 2005, and a fellowship in pediatric infectious disease at the same institution in 2008. Dr. Benary is an associate professor of pediatric infectious disease at Stony Brook Children's Hospital, where she joined the faculty in 2008. She's also a program director for the Pediatric Infectious Diseases Fellowship Program. Her research interests include infection control and hospital epidemiology, vaccine clinical trials and education, tuberculosis drug and vaccine development, pediatric transplant, and Lyme disease and tick-borne infections. Please welcome Dr. Fisher.
Good morning, or almost good afternoon, everyone. So I think part of the point that I'm going to come with today from a pediatric perspective is, it's very important to do education on what can happen with Lyme disease. I'm also here to tell you what does happen. And in pediatrics, it's a very treatable and curable infection. There was a recent article, as noted here in the New York Times, that talked about a child who had Lyme arthritis, got 4 weeks of antibiotics, and did wonderfully. So again, Lyme disease in pediatric patients may present a little differently than adults, but is a very curable disease. So I'm just going to give you a big overview right at this point. Essentially looking at all the reported tick-borne diseases in the United States, and this is data from the CDC from 2016 and 2017. You can see, we see most commonly is essentially Lyme disease. There are certainly other tick-borne infections that we need to think about and test for, but essentially a large majority of what we're seeing right now is Lyme disease, particularly in pediatrics. I bring you to this slide now. My focus is really going to be on Lyme disease. I will talk a little bit briefly about anaplasmosis and babesiosis in children, mostly focusing on the infections from the Ixodes tick. So as you'll see on this slide here, if you look over here, you'll see that this is data from the CDC. The most common ages are boys 5 to 9 years of age. So again, Lyme disease is very common in pediatrics, particularly in boys who are out running around in the woods and having fun. Not to say that girls aren't adventurous as well, but this is what we've collected in the data and the research. And so again, Lyme disease is pretty common in pediatrics, very treatable. So presentations of Lyme disease. Essentially in pediatric patients, this comes in 3 major forms. Early disease or the erythema migrans rash, and that's typically seen within a few days if it's going to be seen. Again, as you've heard, sometimes people get a tick bite but realize they've been bitten and miss the rash. And again, the tick can go to areas that we're not typically looking at. So, we pull ticks out of belly buttons, between toes, behind ears, off the groin, private areas. So again, sometimes it can be missed. Usually, if you're going to see it, it's going to present within the first few days. Early disseminated forms of disease usually takes up to a few weeks. Essentially, those forms are multiple erythema migrans rashes, so you see multiple rashes. Again, they don't always look like a bullseye, so it's important to be aware of what the rash looks like. We'll see meningitis on occasion in pediatrics as well. Facial palsy is a pretty common thing we will see. And we certainly see a number of cases of Lyme arthritis. That's a later manifestation of Lyme disease. That can occur months to years later, so that we might see in the middle of the winter, whereas the other forms of Lyme disease typically present, as noted, between April and October typically. So diagnosis. So we do not test the tick. We don't recommend that for research purposes. That may be done, but for clinical care, we do not test the tick. We don't recommend testing the tick. We do recommend identifying the tick species because it's important, as you've seen, to understand the tick species in order to know what infections might have been transmitted by that particular tick. For the Ixodes tick that transmits Lyme disease, anaplasmosis, and babesiosis, we also can tell you about how long it's been attached. So at Stony Brook, we do something, we look at the Scleral Index, which tells you how engorged the tick is and the time of attachment. And this is critically important because it helps us understand what are the risks of transmission of getting the infection. So again, it's a matter of how long the tick, what kind of tick it is, how long it's been attached in terms of understanding what your risk for is getting any of these infections. So the nymph usually takes 36 to 72 hours to transmit the bacteria. In regards to the adults, it can take even up to 72 hours. So again, it's really important if you do see a tick to remove it immediately. The sooner you take it off, the better the chance of decreasing the risk of transmission. We certainly do test people for the infection. We do not actually look for the Borrelia bacteria in the blood directly. We're looking at your immune response to the bacteria. So the issue with that is your immune system takes time to build a response to an infection. So often early on in early Lyme disease, we don't always get positive testing. And so at that point, it has to be a clinical diagnosis. You have to understand what the patient is experiencing in terms of clinical symptoms and certainly recognize the rash. And at that point, we treat without testing. Whereas if you present a bit later with other symptoms, such as fever, maybe disseminated rash, facial palsy, signs of a severe headache, then we would consider doing blood testing to make a clear diagnosis. And certainly if you have arthritis, we're also going to be sending testing as well. And these testings are things called IgM and IgG. So just to go over the tests in more detail, because this becomes an issue for us, we get a lot of questions about the actual testing. So again, in early disease, it's a clinical diagnosis, and we typically don't do testing. But in the other forms of Lyme disease, we will do testing. And testing is two-step testing. So you always want to do a Lyme screen first, because again, there are false positives and false negatives with testing. We really want to understand first, what your overall antibody response is. So that's the Lyme screen, the EIA or Lyme C6 is a newer test that can come positive a little bit sooner for Lyme disease. Then we do the Western blot. That's the second step of testing. And there are two antibodies, IgM and IgG. IgM occurs very early in infection, within the first 2 to 3 weeks, generally, and peaks at 6 to 8 weeks and then declines. IgG appears at 4 to 8 weeks, and then peaks at 3 to 6 months. And IgG can remain positive even after cure. So again, we're taking all this into account. We're looking at the Western blot, we're looking at IgM. There's so many bands you should have. And then we're looking at IgG, and there's so many bands you have. And so we look at these in combination and decide at what stage of Lyme disease you have. And again, because these IgG antibodies, those are antibodies that stay positive for life potentially, there's no test of cure. So we don't recommend after a course of antibiotics of retesting the patient. It doesn't mean that we wouldn't test you at a later time if we thought you had a new infection. We would look at the clinical picture, we would repeat lab work, and we'd look at your previous testing and do a comparative comparison of the two tests to decide if you have a new acute infection. In terms of, again, how it presents in pediatrics and others as well, as a pediatric infectious disease doctor, I don't often see too many of these cases because most of the pediatricians are doing this in their office, but we do get often pictures being sent to us. And essentially, it's a clinical diagnosis, as I mentioned. It occurs within usually a few days to a week or so after the tick bite. It can be missed. There are varying forms of it, and it can be tricky to see. You might miss it if you don't really kind of take a look in the scalp sometimes. Obviously, can be a very severe form, but adolescent colitis in particular, or other patients too, may not be willing to share, very private sometimes. And then sometimes it's behind a leg or in a place where you're not going to really see it. So again, it's important to keep this in mind when you're thinking about Lyme disease. Again, serology is negative, it's clinical diagnosis and treatment. Disseminated forms. One of the disseminated forms I mentioned is the central nervous system. We've heard a bit about that. In pediatrics, there was a study a number of years ago that looked at the prediction model. Thinking about, again, it is a bacterial infection. It often, as noted, can present as a viral aseptic meningitis. The particular things that distinguish it a little bit from a viral meningitis. So these are some of the things that we look at. And one study looked at what we call the rule of sevens. So if you had less than 7 days of headache, then it would be less likely to be Lyme versus potentially viral. Usually a viral infection is very acute. Lyme disease usually somewhat prolonged headache typically. When you do the spinal tapping, again, that's helpful in making the diagnosis. When you look at the type of white blood cells, they should be what we call mononuclear cells. So there's the cells you typically more see in viral meningitis and Lyme meningitis. And these types of cells help us decide if this is that versus, let's say, a bacterial infection. We have different types of cells. And they should be at least 70% or more. If they're less than 70%, then you're less likely to think about Lyme meningitis. And the second nerve palsy, so that facial palsy, when we see that and have severe headache, prolonged headaches, you really want to think about central nervous system, Lyme disease, and think about a component of meningitis. So if you don't have these, then the probability of having Lyme meningitis is less than 10%. So we do kind of keep this in mind when we're working on the patient. In terms of pediatric patients specifically, cognitive and memory difficulty alone is not diagnostic of Lyme disease. We certainly want to look at the big picture, but they're going to generally present with other symptoms as well. We're going to think about the rule of sevens when we do the workup for them, in terms of prolonged headaches, facial nerve palsy, and the lab testing results. Oral doxycycline can be used in central nervous system Lyme disease. I'll speak a little bit again about that at the end. Pediatric patients rarely present with other CNS manifestations. So really the main things we see in pediatric patients are the meningitis and the facial palsy or relative. So another form, probably we didn't talk too much about, is carditis. Again, the Borrelia bacteria do sometimes go to the heart. This is a rare presentation in pediatric Lyme disease. Essentially, it's much less common in adults. We do consider doing EKGs to diagnose in patients that present with very particular symptoms. So they may come in with palpitations, chest pain, shortness of breath, may have passed out. We do want to think about Lyme carditis and at least order an EKG in addition to Lyme serology. There is, after that we would get cardiology involved. Rarely do pediatric patients need to be paced briefly. I've never had a patient that required a long-term pacemaker. And again, it's diagnosed by serology and is a very treatable infection. Will do very well. Lastly, Lyme arthritis. This is very common in pediatric patients. Usually presents as generally not unpainful, non-painful swelling of the knees. 90% of the time it's knees. I've seen Lyme arthritis present in other joints, but in pediatrics, particularly the knee. It's unlike an other bacterial arthritis where you see red swollen joints. This tends to be, normal, not hot, not red looking, but very swollen, very rarely painful. And we often recommend, in addition to antibiotics, we do recommend anti-inflammatories because it's a big component of inflammation in this particular infection. So regards to treatments, I have already mentioned that erythema migrans is a clinical diagnosis, and the American Academy of Pediatrics now recommends that you do as short as 10 days of doxycycline or 14 days of amoxicillin. We do use more doxycycline in pediatric patients now. Studies have shown that it's safe to use, at least up to 14, maybe 21 days in pediatric patients. We generally won't use it longer than that. Essentially, in the past, there was some concern about tetracycline and tooth staining. Doxycycline, although it's in the family of tetracyclines, it's different than doxycycline. That's the most of the concern, so we feel a lot more comfortable using doxycycline in pediatric patients. It's not to say we don't use amoxicillin, but we're using a lot more doxycycline. For early disseminated forms, so again, this is the multiple erythema migrans, rashes, meningitis, facial palsy, and carditis. We would use 14 days of doxycycline or amoxicillin. But I just want to point out for meningitis, we would use doxycycline, and we still do use isotretinoin as well. It kind of depends on the clinical situation and the particular patient. And late arthritis, we would use 28 days of doxycycline. So that form of Lyme disease we typically treat the longest in pediatric patients. So I'll briefly touch on anaplasmosis. So this is another infection that's transmitted by the deer tick. It's actually not very common in children, but the frequency may be increasing. So there are some studies that suggest that kids may be less susceptible to anaplasmosis. So maybe that's part of the reason. And then another reason may be that in general they have milder disease. So maybe they're able to clear the infection and they don't present to care in the same way as adults might. Usually you would present 5 to 14 days after Lyme. So in someone who's been treated for Lyme disease, and sometimes in pediatric patients we're using amoxicillin, so we're not using the doxycycline that would normally treat other tick-borne infections. If someone's not getting better as expected, we might reevaluate them and think about other tick-borne infections. But I can tell you this is very uncommon in pediatric patients. One study had found that a quarter of the patients that did have co-infection had increased risk of hospitalizations, but the numbers were small. So again, in a sicker patient with hospitalized, we're certainly going to think more broadly about tick-borne infection. And again, even for pediatric patients, doxycycline remains the treatment of choice for this infection. In regards to the babesiosis, again, it's something we don't see too commonly in pediatric patients. The cases that we do see are really in the neonates, the youngest. And then we will see that occasionally in our immunocompromised patient, we had a young child with cancer who developed very severe form of babesiosis. So again, that lack of a functioning spleen, most pediatric patients are healthy and generally do well, and so that they can often clear parasite on their own. They often don't have symptoms like adults do. So it's definitely a very different presentation than we see in adults. And again, we very rarely do treat it. So I'm not going to talk too much about this because we have the next speaker coming up. But again, what can you do to prevent Lyme disease? Again, regular tick checks, again, looking everywhere. Again, the sooner you remove the tick, the better. If it's ear tick, we will consider, even in pediatric patients, if it's an identified ear tick removed and treatment can begin within 72 hours, we will recommend a one-time dose of doxycycline. In clinical practice, this may be unrealistic for some pediatricians because they have so many patients coming in with ticks and constantly pulling off ticks. But in certain scenarios, if the parents are concerned or you're concerned as a doctor, then it may be something to consider a one-time dose of doxycycline in order to try to prevent, almost prophylaxis to prevent potential Lyme disease. Other option would be, if you know it's a deer tick, to consider testing 4 to 6 weeks later to see if the patient has developed Lyme disease. And certainly you're going to continue to monitor over this whole period of time to see if you develop any signs or symptoms of Lyme disease. Again, protective clothing, I'm not going to go too much into that. We do recommend insect repellents. Certainly avoid tick-infested areas, but try to tell that to a 9-year-old boy. So again, you also want to think about your yard, because a lot of people will tell us that you're in their yard, and there's some ways you can prevent that as well. The CDC has a lot of good information about how to set up your yard, and some recommendations for tick prevention in the yard. And then we often recommend if you're gardening, you're going to be outside, and you want to come in, throw your clothes in the dryer to help kind of kill the ticks. And again, tick checks are really important, bodily tick checks. And lastly, what are we doing at Stony Brook? So we're, increasingly doing tick research. One of the things we're currently doing now is some newer diagnostics, something called next generation sequencing. Again, looking for the specific bacteria and seeing if we can maybe understand Lyme disease a little better in terms of diagnostics. And then we're also looking again, because there's some controversy or question about treating Lyme meningitis with oral doxycycline. So there's going to be a multi-center study that will be involved in looking at Lyme meningitis treatment in pediatric patients, whether doxycycline or IV ceftriaxone, which one might be better, and if 2 weeks is just as good as 4 weeks. Our recommendations and our guidelines currently do say that doxycycline for 2 weeks should be adequate for Lyme meningitis in most pediatric patients. But again, there are scenarios we're certainly still using IV ceftriaxone, and I think the study will kind of enlighten us on what the next step should be and how we treat these patients. But again, very treatable infection. It's just a matter of recognizing the disease and treating it appropriately. Thank you.
Thank you, Dr. Bernard. And our final speaker, we're just about there, folks, is Gerald Simons. Jerry Simons is a registered physician assistant. He graduated from SUNY Stony Brook's Health Science Center with a degree in cardiorespiratory sciences, and went on to graduate from Cornell University Medical College's Physician Assistant Program. He's nationally certified as a physician assistant with commendation in both primary care and surgery. Jerry is a clinical assistant professor and on the faculty of the Stony Brook University Physician Assistant Program and is an instructor at several major universities. Jerry is a member of the Medical Advisory Panel to the Regional Tick-Borne Disease Resource Center. He's an award-winning international medical education lecturer. He has developed educational programs used by physicians and health providers and is a published author on Lyme and Tick-Borne disease. In 2010, he won the National Award from the Tick-Borne Disease Alliance. He also practices at the Morrison Center in Watermill. Jerry will be talking about prevention tips. Please welcome Jerry.
Thanks. So just before I start, we're going to take a quick survey. If you've had a tick bite on you this year, just stand up for us really quick. Let's see. Got it. Okay. All right. Good. Interesting. Excellent. Okay, so I'm going to talk about prevention. Just make sure if you haven't grabbed one already, on your way out, I definitely have my guidelines on it. But really the take-home point is you have to protect your clothing, you have to protect your skin, you have to keep wildlife out of your yard, and you have to also manage your pets as well. So we're going to talk about these kind of different layers. And people talk about literally being in a tick-nado, not a tornado, but a tick-nado, because there's so many ticks around. You've actually seen bumper stickers. There's a famous one in East Hampton that says, "From Springs, ticks love us." There's actually bumper stickers out there. So when you think about the important thing, everybody's kind of nervous now about all of the different diseases. But we're here to tell you that these diseases really are 100% preventable if you can keep the ticks away from you and get the ticks off of you pretty quickly. So when people say, Jerry, what's your elevator pitch about a tick bite? I'm like, okay, a tick bite is like stepping on a dirty needle. When it pokes you, you don't know what that needle stick, what that tick bite actually is going to transmit. Think about it. Ticks live in the dirt for 2 years. They drink the blood from mice and rodents and birds and all kinds of nasty stuff, raccoons. So prevention is vital. Since ticks are so small, you may not see them on you until they're actually engorged. And some people come in with a tick bite, and we're always worried about what other tick they might have on them, maybe more than one. That's a famous picture of your kids' Lego pieces. Just think about how small those ticks are. They can fit on. Of course, we're in peak war zone now, right? June, July is where we're seeing the most amount of ticks. People, this is when you want to leave here being the most vigilant, right? And like we already heard from Scott, really, this is a year-round problem. We don't turn off our tick alarms come Labor Day, right? People have submitted pictures. Look at this, guys. This tick is crawling out of the ice, and it's coming for you. You know what I mean? It looks hungry, right? Although it just ate, it's fully engorged, but I wanted to get your attention. So think about that, right? It really is a year-round problem. And very interesting, you hear a lot about climate change, but there is a lot of interesting data on the changes in tick infection with climate change. For example, they're seeing Lyme disease, Ehrlichia and Babesia in parts of Canada that a decade ago never even saw ticks. Part of the changes of the types of ticks that we're seeing here and moving north, even in South America, in Uruguay, Argentina, they're talking about tick bites that they previously never saw. And over 19 years of research, they've been seeing in Canada that there's basically a northern invasion of ticks as it gets warmer, as deer migrate more, and things like that. So there's a lot of interesting data about that. Look at this from a Canadian journal, right? Every year, our warmer climate pushes Lyme disease 4 kilometers deeper into Canada every year. And again, those doctors there are not as familiar with Lyme as we are in Southampton, so they don't really understand, like if someone comes in with flu-like symptoms in July, they're not used to seeing Lyme disease there. So again, the temperature change, the climate change is definitely happening. Even now, in Maine, Vermont, New Hampshire, people talk about endangered species, and they're worried about the moose population because baby moose are dying at record numbers. They're finding up to 47,000 ticks on one moose in New Hampshire, decimating the baby population of moose. So people are like, wow, save the whales and save the endangered species. I'm like, what about the moose? That's a big, big problem also, right? Look at this quote, people. The moose are literally being drained of their blood. It's about as disgusting as it gets out there. So if we see 47,000 ticks on a moose, think about what we're seeing on a deer, right? And as we already heard very briefly, the tick gets infected by feeding on one of these animals, a bird, right? A mouse, chipmunks. You guys have to do whatever you can to get these guys out of your yard, right? When you're attracting birds with bird feeders, they're dropping ticks. The bird food is attracting mice, rodents, squirrels, things like that. You have to get wildlife out of your yard. Also, people are like, wow, how did my cousin get Lyme disease in Central Park? And there's Lyme disease in Central Park as the birds migrate there and drop the ticks. That's one of the ways that people are getting infected, right? Reducing deer exposure also is critical. The 4 poster system, which has been used in Nantucket, Cape Cod, Shelter Island, to help reduce the deer population reduce the tick population on deer, has been really wildly successful. So think about cleaning up your yard, working on both deer exposure and deer population also is really important. All of these, the cardinal, the chipmunk, the deer, they're all carrying ticks, right? Remember, these ticks can have hundreds of babies. So of course, the deer gets, or the tick gets infected, and when you get bitten by that tick, that's how it's going to transmit this infection to us and of course to our pets. So we've heard a little bit about the tick life cycle already. The tick is born, the 3-legged larva, it gets on a mouse and a bird. If you get rid of your bird bath, your bird food, you get rid of your brush piles and your bad compost piles where you attract a lot of mice, you're getting rid of the important vectors there, right? The nymph, right, which is like a hungry teenager, is going to look again now for people or deer as it goes through the life cycle that way. So we can really start at the basic level, getting rid of mice and rodents and birds to help us reduce some of these infections. So what are you guys going to do in your yard, right? Get rid of mice, get rid of chipmunks. We definitely know that ticks will rarely cross a 3-foot wood chip border. So you'll see that a lot of landscapers that specialize in getting rid of ticks will encourage around your deck, around your living area, around the perimeter of your yard to put 3-foot borders of wood chips to keep ticks down, right? There are different kinds of tick boxes, which have been, through the CDC, wildly successful at reducing the amount of ticks that are carried by some of these rodents. And Brian Kelly was reminding me that, of course, owls are natural predators for a lot of these rodents. So owl boxes is like one of the hot new yard items for your Hamptons backyard. Attracting owls will help you get rid of some of these bad guys. Guys, go home, get rid of brush, get rid of wood pile. Get your compost up and off of the ground so you're not attracting these bad guys. Of course, we've talked a lot about the white-footed mouse, right, which is one of those big vectors. So get rid of those mouse appetites. Get rid of birds, right? Some of you have seen when you go to the local Ace Hardware store, there's my picture with a wanted ad, right? They're like, Jerry, your lectures have destroyed our bird bath sales and our bird food sales, right? But I'm like, hey, haven't I increased your wood chip sales? Because everybody's making 3-foot borders now, right? So there's a lot of hardware guys that don't like it. But look at this beautiful picture. Think of how many ticks these birds are dropping in your yard as they're there. Think of how much bird food is spilling over and attracting the mice and the squirrel and the chipmunks. Guys, these are easy things you can do, right? Keep grass short, right? I'm waiting for that 2-inch thick Hamptons magazine that is outside of every real estate office. You guys have seen them, right? I've been pushing them. Give me some nice brown lawn on your cover. You don't want lush green lawn to attract ticks. Brown is the new green for lawn color, okay? It's actually good. Use plants and shrubs that don't attract deer, and consider deer fencing if you can manage that. As we've already heard, guys, it's pretty obvious, right? Stay away from the tall grasses. Stay in the center of the path. Better yet, go trail hiking in the fall after this emergency season is over. Wear long pants, light colored clothes, and use repellents. So, important part of prevention is thinking about your skin and your clothing. There's an old wives' tale, it's never been officially published, but it's been known for a long time. Ticks hate the scent of lavender, right? Lavender dryer sheets, shampoos, soaps. I've shoved lavender dryer sheets in my kids' pockets to kind of keep ticks away, right? Using DEET or eucalyptus on your skin and permethrin on your clothing is probably the most amazing thing I can tell you guys today. Most amazing thing to keep ticks off of you. You need one thing on your clothing, like permethrin. That's that famous yellow bottle over there. DEET or eucalyptus, which can be applied directly onto your skin. And we've got guidelines exactly on how to use those in the back, right? They do have impregnated clothing. They have them at Devour, and a lot of people have basically put the permethrin on clothing for you, but you can easily do that yourself at home. Now, there's actually been some scientific literature on these different types of repellents to give you an idea of when you go to the store scientifically, which one you should buy. Because guys, come on, I've got the same problem you do. You go to a local barbecue, you go to the 4th of July parade the other day, you talk to 50 people, hey, how do you get rid of ticks? You're gonna get 50 different answers. Everybody's got a different story as to what works for them. So it's nice to actually have some published data to give us an idea of what is worth buying when you go to the store, right? So basically, this is specifically on mosquitoes, but we found actually that it correlates a lot with tick bites. But this is the amount of mosquitoes attracted after 4 hours. And of course, DEET worked really well, right? But look at this, lemon eucalyptus, right? A really natural one, was almost tied with DEET in a lot of this different data. That's that greenish bottle with the orange label. You can come look at my collection later. So one thing to remember, get DEET or get lemon eucalyptus, and you can apply that directly to your skin. I've got my handout here, you can grab it back, which gives you more data on that. So you're protecting your yard, getting rid of birds, getting rid of mice. You're protecting your clothing with permethrin. You're protecting your skin with eucalyptus or DEET, right? So DEET, and we've actually got a flyer on this, and you don't need me to read all the data to you, but basically I'm here to tell you that DEET on your skin actually works good to keep the ticks off of you. DEET on your skin works good to keep the ticks off of you. And Sky here helped to develop this slide, which is great news. One interesting thing is a lot of people are buying these combination products where they have DEET and sunscreen combined. They really don't work that well. You have to buy them separately. Okay, so shoppers beware, right? Don't really use sunscreen and DEET, right? Because it won't really protect you from the sun. DEET will stay. Picartin, right? Picartin, of course, which was originally derived from black pepper. And this works really good in the fall for those of you guys are afraid of getting Lone Star ticks. Guys, quick advertisement, my own research. When patients have come to me with a Lone Star tick bite, I say, do me a favor after your Lone Star tick bite. Don't eat any meat for 2 weeks, just to not introduce any potential trigger. And I've seen those people not getting as much alpha-gal. Not officially studied, just kind of an interesting idea. Don't eat meat after a Lone Star tick bite. So this actually works well, of course, as a repellent as well. It's been used in Europe for years. And of course, permethrin, right? I would change my middle name to permethrin because it works so well, right? But just use it on your clothing, right? Use it on your shoes, things like that. You can get it as typically as an aerosol spray. Look at this, permethrin impregnated clothing, right? 100% protection against ear tick nymph and wart. Guys, clean up your yard, use something on your clothing, use something on your skin. You with me? Okay, good. Here's another big article that came out, that talked about the use of permethrin, specifically against ticks. And we do know that permethrin on your clothing can survive this high heat, at least for about 4 washings. So as you already heard, one of the best pieces of advice, get home, strip down, put those clothing in the dryer. The heat will kill the ticks. Don't put them in the washer. Run them through the dryer, or you're doing a quick tick check that way. There's another one called IR 3535, or Insect Repellent 3535, which has been around since the 80s, and it actually comes from beta-alanine, which is an amino acid, which is a version of vitamin B5. So it is synthetic, but like the carton from black pepper, it is kind of naturally based, right? And these work specifically well against aerosol and irritant. So you guys have to be informed shoppers, whether you're going to use DEEP or eucalyptus, the carton, IR 3535, there's a bunch of products that are out there. And you're going to pick up our guidelines on the way out. Another one of my favorite ones, oil of lemon eucalyptus. I have 2 teens at home, and I'm not keeping them trapped in the house. They use eucalyptus on their skin, and then they use the permethrin out on their clothing. And that was shown also to be really good, but kids under 3 are very sensitive to this, so you're going to avoid using that product. There is a lot of interesting data in the veterinary community about using these essential oils, right, to help prevent dog ticks. A lot of people in Montauk love to lather themselves down with cedar oil, and they're not getting a lot of ticks that way. So there's some new and emerging data comparing that to beef as well, right? We've got a lot of different studies on this. But again, if you're running out of ideas, eucalyptus on your skin, and use permethrin then on your clothing. Now, here's one of my favorite slides, the Environmental Working Group. Guys, the Environmental Working Group makes my gold card Sierra Club look like Dick Cheney. These guys are more about the most liberal environmental group you can get. And we're here on July 4th weekend to tell you that the Environmental Working Group, a very liberal environmental group, says you can use Pucartin, you can use some DEEP, you can use IR 3535, because the risk and the manifestations of those tick bites are worse than a temporary exposure to some of these chemicals. Got it? Okay, you can go right to their website, at ewg.org, and it got a great breakdown. See how big important the slide is? It doesn't want to change. Oh, there we go. Great. So use repellent, right? Again, my favorite. Oil of lemon eucalyptus and permethrin on the clothing. Tucking pants into your socks, right, to create a really good barrier. Guys, you guys have been up and down Job's Lane. This is the hot style of July, right? Also, I really love it when people use a lint roller. As you're kind of walking around, as you're outside gardening, take the lint roller and once in a while roll it over your pants. If there's any ticks on you, it'll help to grab it, right? Also, if you're really going into a crazy spot, you can take duct tape and put it sticky side out, kind of around your sock area there. Duct tape, lint roller, socks out. Guys, it's the hot style, right? It's going to be on the cover of Dan's papers, right? And make sure you wear light colored clothing as well. So, what are you guys going to do for yourself? Stay away from long, tall grasses. Use eucalyptus or DEEP, use permethrin, check yourself regularly, carry a lint roller. Just very briefly, what should we be doing in our community? Guys, I'm not here to talk about deer culling or what to do with the deer population, but I will tell you the 4-poster system is breathtaking. It's wildly successful on Shelter Island, with the amount of tick bites and Lyme has been going way, way down, right? Who pays for it and cleans it and keeps it filled? It's a different issue, but we love the 4-poster system. For pets, please keep pets out of your net. Keep your dog out of your net. That's where they drop all of their ticks. And we're kind of running out of time, but in my handout here, I've got a great section on how to talk to your vet and what to do about your pets. Remember that you really need to remove ticks as soon as you can. The alpha-gal allergy can be transmitted in an hour or so. Powassan virus can even be transmitted in 15 minutes, right? So if you see a tick on you, just stop what you're doing, get rid of it. If you have a piece of tape and an index card, tape it down and keep it in control that way, right? So we've kind of already heard what do we do if we get a tick bite. Like you've already been shown that great video, you pull it out straight perpendicularly. I like good old-fashioned iodine, like Betadine. It seems to kill everything, and then a little bit of bacitracin right over the top. So guys, a reminder, prevention is vital. All of these diseases are preventable, right? Treat your shoes. This is where a lot of ticks come into contact. May through July are the peak risk factors. Ticks hate lavender, use something on your skin, something on your clothing. Get those beautiful little Disney animals out of your yard, the mice and chipmunks, the birds, right? Avoid tall grasses. Do tick checks. Do tick checks. On my handout here, about the third page in, I've got a beautiful picture of a naked body with all of the areas where ticks tend to hide. So guys, when you're doing your July 4th romantic dinner with your significant other at home, right next to the candle, put this document. And you'll say, I was told today I need a thorough tick check done. Right? And you start taking your clothes off and it should be perfectly legal. You can take this to the Red Bar, put it on Tinder. It's all yours, right? However you want to help your relationship, that's the way to do it. Okay? And remove ticks and save them. You've heard about the Tick Encounter resource, tickencounter.org, which gave us some of these pictures and references. That's a great, great website. And you've got our contact info here. Guys, the other good news is we've already purchased these for you. It cost us about $8. So even a couple dollars on your way out to help us buy the next set of kits, you can talk to Karen in the back there. She'll take your $3 or whatever you think you can help us with. Great, so I'll pass it back over to Bob, and I think we'll be open for questions.
Jerry, just one clarification, because somebody said this to me once, they heard you talking about iodine and they should put iodine on before they take the tick off. It's take the tick off first, never put anything on the tick, right? It regurgitates potentially. So get the tick off